So, obstructive sleep apnea is a very common disease, but very severely underdiagnosed disease because
People at the low risk or at least moderate risk.
so, as told, people who don't have a very active lifestyle, more sedentary lifestyle, who are slightly on the higher weight range,
I think CPAP can bridge the gap between.
CPAP is required for everybody.
Okay.
Till the cause for that OSI is resolved.
Welcome to India's first health podcast channel, National Health Diary. Today's topic is obstructive sleep apnea. To talk about this, we are having today a renowned pulmonologist of Bangalore who is specialized in treating obstructive sleep apnea, Dr. Sagar. He is also specialized in treating other breathing disorders and lung diseases. Dr. Sagar, welcome.
Thank you.
So, as you know, our today's topic is obstructive sleep apnea. So, I want to know, and also our audience wants to know, what is obstructive sleep apnea? And this is something very new. There are a lot of patients who know about fever and cancer, all the other diseases, but this is something term which people are not aware about.
So, obstructive sleep apnea is a very common disease, but very severely underdiagnosed disease. Obstructive sleep apnea, as name suggests, it is obstruction to the airflow which appears during the sleep, and if that obstruction episode is more than 10 seconds or even more than that, that episode is called as apnea. So, obstructive sleep apnea, usually it is seen in people who are obese, like overweight, and so this is the most common subgroup of population who have this disease. And the people who have some craniofacial abnormality like micrognathia, whose mandible is slightly smaller, and retrognathia, whose mandible is slightly behind the usual position, and people with macroglossia like thick tongue or enlarged tongue, and a large palate, and a few people who have this tonsillar hypertrophy, especially in people in pediatric age group, they have this adenoids. So these are the few associations with the obstructive sleep apnea, which can cause obstructive sleep apnea.
Okay. So what happens actually in sleep apnea?
So in sleep apnea, basically the passage, the upper airway, so that's a very thin area through which the air passes in and out.
Right.
So usually when we are sitting, the passage is more wider and the airflow is smoother. So when a person assumes the horizontal or reclining position, so there is compromise in that area. So usually in people who are fit in the sense like their weight is adequate for their height, like who are having proportionate weight, so there is no blockage because the airway will be still patent when they are in sleep. This area gets compromised. So because of the gravity, these tissues come closer to the posterior pharyngeal wall, the backside of the throat. So that area gets compromised and airflow in the lighter stage of the sleep becomes more turbulent. That's when the snoring occurs. Visual, like whatever the CT we tell.
Right.
So when we blow air through a narrow aperture at high speed, then the sound occurs.
Right.
The same situation arises in the upper airway during the lighter stage of the sleep in people who have obstructive sleep apnea, and they snore louder. And when they go to the deeper stage of the sleep, the tone of the muscles will be lost. Hence, the tone of the tongue, the parapharyngeal muscles, the tone of those muscles will also be lost, and there will be collapse of the upper airway. So, hence, complete obstruction to the airflow occurs. The air can't move inside or come out. Hence, there is like reflex drop in the saturation and increase oxygen levels and increase in the carbon dioxide levels. So the person should die if at all that choking is not opened up, obstruction is not opened up, the person should die. But our body has an excellent mechanism. There are chemoreceptors, like there are chemical sensors in the aorta and also the carotid arteries. So they pick up this drop in oxygen saturation and send reflex impulses to the brain so that the person is woken up. In normal people think that they will get up from the sleep and sit. So that doesn't happen. There will be a arousal, in the sense from the deeper stage the person is woken up and he comes to the lighter stage. So the airflow is restored, but the snoring starts again. Okay, usually this was the event what we see in people who have OSA.
Simple words, there's a pipe
which is blocked. Yeah,
breathe and the pipe gets blocked.
Yeah.
It's nothing to do with the lungs.
It's in the upper airway. We divide the respiratory system into upper airways and lower airways. So the larynx, the voice box. So above that is the upper airway. Below that is the lower airway. So everything happens in the upper airways. There is nothing to do with the lungs or the airways. Yeah.
The pipe is getting blocked.
Yeah.
In simple terms, there is a blockage. And that is why the
intermittent blockage, which will open up because of reflex arousals. Yeah.
It was a very good explanation what is sleep apnea in simple terms.
Yeah.
So what do you think, apart from the anatomical deformities, what other can be the causes of sleep apnea?
So
obesity is one, what you have
see, basically everything boils down to the upper airway abnormality only, whether it is because of weight or whether it is because of the walls which form the upper airway, like tonsils, soft palate, the tongue, or because of the retroposition of the maxilla or mandible. So there is an anatomical abnormality. Without anatomical abnormality, the obstructive sleep apnea can't happen at all. Okay, so sleep related breathing disorder or obstructive sleep apnea happens only because of compromise in the upper airway. This is for sure.
Yeah. What are some of these symptoms through which people can pick up that they have sleep apnea?
So for people to understand or pick up the symptoms of OSA, or in the family if anybody has OSA or not, to take, there are few simple symptoms what we can observe. So first thing is snoring, but all snoring are not OSA, but snoring is one of the important symptom of OSA. And recurrent visits to washroom to pass urine in the night time, and early morning headaches, heaviness in the head, unrefreshing sleep, and lethargy in the morning only, and feeling like sleeping for 1 or 2 hours more. These are the morning symptoms. And over the day, the people will feel more lethargic, more tired. And in few people, they'll have lapses in memory, forgetfulness, and they are agitated, short tempered. So chidchidapan, what we tell in Hindi, so that will be there. And excessive daytime somnolence means if left undisturbed, they sleep at unusual places, probably when waiting for a doctor's consultation, or sitting and watching TV while traveling in public transport, or in the park. And one of the most common causes of accidents in obese people is OSA. So we have seen a couple of patients who have come to emergency with accident, and there was no vehicle which had hit them or anything like that. They were driving in a highway at their own pace, and there was no vehicles also because of this OSA. And they tell, I don't know what happened. I was blacked out for some time, and next thing I saw was I had an accident. Yeah.
Okay. People on the wheel, they will
doze off. Yeah.
Okay. So we see, there is one is the obesity, other one is the
anomalies of the face.
Deformities like maxillofacial deformities. Those can lead to the obstructive sleep apnea in adults in general.
Yeah.
You think any sedentary lifestyle, and because people are not doing good exercise, alcoholism, smoking also have some of the other.
See, we can tell OSA is a disease of lifestyle.
Okay.
So see, as you told, sedentary lifestyle, excessive consumption of alcohol, smoking, all these lead to lack of physical activity, more sedentary lifestyle. All these lead to gaining more weight. It might lead to increase in hypertension,
Okay.
and diabetes. And OSA, diabetes and hypertension, all these three can lead to increased risk of stroke or heart attack. And people who have OSA, chances of becoming more getting diagnosed with hypertension, diabetes is more. And
Okay.
people who have OSA and who are already diabetic and hypertensive, the dosage required to control their sugars and the blood pressure, the dosage required will be high. Yeah, so everything is interrelated.
So OSA, blood pressure, and diabetes, all
Yeah.
three are good.
And also dyslipidemia.
Right.
They are all interrelated.
They are all
Yeah.
friends. They
Yeah,
want to be
like
together.
a family. Yeah.
They want to be
Yeah.
together.
Yeah.
One
Yeah.
has come, it will bring other two. Or
They want to be, or they will be together in most of the cases.
Okay.
Yeah.
So it's not that the one has come, that means definitely all
High
two or
chance
three will-
that you
the
can
other-
get, or we should be more concerned whether already we have it.
Okay.
Yeah.
So we should be screening.
Yeah, so once we get diagnosed with OSA, it's better to screen for other diseases also.
Okay.
And people, especially who have uncontrolled diabetes, uncontrolled hypertension, and people who have stroke or heart attack, so all these people should be screened for OSA.
Okay.
Yeah, and if OSA is there, better to get screened for other
For
diseases.
other diseases.
Yeah.
Well, I think OSA is the base where all the diseases are starting actually.
See, as I told, it's a disease secondary to abnormal lifestyle. So, everything will be there together. It's what we diagnose first. So, see, it's where the patient goes first.
Okay.
So, suppose the patient comes to me, so probably I'll diagnose OSA first, and in the meantime, I'll evaluate for this also.
Okay.
Suppose if they meet so we have one excellent neurologist who is very interested or has special interest in OSA.
Right.
So he is screening our stroke cases or cerebrovascular accident cases. So most of them are turning to be having this OSA.
Right.
So say they presented to him with the stroke.
syndrome. Yeah.
So he had a special attention or special curiosity towards whether the patient has OSA or not, and then the diagnosis was made, and then the patients were referred
Right.
to me. So if the patient comes first to me before stroke or something like that, I'll evaluate
Whether they had a stroke
or anything like that
any
in
other
my
symptoms
questionnaire.
of the
Yeah,
blood pressure,
yeah.
diabetes,
And
or-
if once OSA is diagnosed, and again I'll evaluate for this diabetes, hypertension, and all. And if something like high risk of heart attack or stroke is there, then definitely we'll take consultation from a physician or a neurologist and put them treatment for prevention of those things also.
So you mean to say the blood pressure, uncontrolled blood pressure and uncontrolled diabetes, if anybody is facing, they should definitely screen.
At least they should themselves evaluate, like with a questionnaire or something like that. Have I got the symptoms of OSA? And it is better to get tested for OSA. Yeah.
So how do we diagnose? Like how do a person confirms?
Suppose a person comes to me with suspicion of OSA, or usually the family members bring them because they snore
Snoring a lot.
very loudly. And other symptoms like lethargy, increased drowsiness, and all. So when they come, usually straight away we don't go and test the patient for obstructive sleep apnea. So I already told there are many questionnaires,
Right.
to see whether the test is necessary. What is the possibility of the patient having this disease? So what I generally use is something called Epworth Sleepiness Scale. This tells whether there is an excessive daytime somnolence, whether the patient becomes drowsy or increased tendency to sleep during the daytime. That questionnaire helps us. It is a very simple questionnaire. It is available on the net. Anybody can apply it. So in this stop banks, snoring, if it is there, yes. And tiredness, excessive tiredness during the daytime, yes. And observed apneas, if the family, wife or something like that, he snores continuously, and there is a pause, and with a snort again he starts snoring. So if that is there, yes.
So they are snoring and then
Ah.
stop in between.
And again they start snoring. So if it is there, +1. And blood pressure, if it is there, you +1. And BMI like more than like 28 and all, that is +1. And age more than 50 years, +1. And neck circumference 16 inches for females and more than 18 inches for males, that will be +1. And gender, male is +1, female is no score or 0 score. So this is the
male
simple.
Who is having snoring, that means he should be screened.
Male with snoring and any one of the other, I'll be more eager. Yeah. Age more, male like who is more than 50 and more obese, like that. So male preponderance is slightly more. Yeah.
But it happens in females also.
Absolutely. Yeah.
But male have the more chances.
Yeah, more chances, because one score is already yes in that. Yeah.
Sir, how do we diagnose it, and how do we confirm the diagnosis that somebody is having the sleep apnea after we have come down to the questionnaire? Suppose a patient is having 3 or 4 score, then how do you confirm it clinically?
So like once the suspicion, like the patient having that OSA is more, like a probability of the patient having that obstructive sleep apnea is more, we subject him to a test called overnight polysomnography. So as the name suggests, the test will be done overnight. Somno, the test will be done in the sleep. And graphy means recording. Okay, right. Like ECG, EEG, like that. So this test has multiple parameters which should be recorded. One is like electroencephalogram, electrical activity of the brain, and electroocculogram, the electrical activity of the eye, and electromyogram, the electrical activity of the muscle, and snoring, airflow in the nose and the mouth, and the body position, the respiratory movements, ECG, and the limb movements, and also oxygen, like the saturation of oxygen during the sleep will be measured. And there are 3 levels of sleep study, like level 1, level 2, and level 3. Level 3 is the basic one. So this doesn't measure the electroocculogram and electroencephalogram. Like these two are very important to know the stage of sleep. And for in simple, like not very complicated patients who don't have many comorbidities and only like OSA we are suspecting, then we can use this test. This can be done at home only. And in people who have comorbidities like coronary artery disease or previous history of stroke, and who have diabetes, hypertension, and all, these people require stages of sleep also, more comprehensive test, like level 2 or level 1. In the sleep stages also will be measured. So like level 1 is done in the hospital. There will be a sleep technologist who will be there in the hospital monitoring the patient and also monitoring the recordings. Okay. So if there is anything, any abnormality or anything like that, he can correct that then and there itself. And level 2 is the same, whatever the study in level 1 we do it at home, but there will not be any technologist monitoring the recording. Attending the recording. So these are the 3 types of tests which are most commonly used. But newer technologies are coming, like something called actigraphy. So, and peripheral arterial tonometry, these are the new tests which are coming up. So they require further validation, and more widespread use might happen in the future.
Standard practice, what we have is, one can be done in the hospital, other one can be done at home. And at home there are 2 types. One is more simpler one, but that can be done with different group of patients. But somebody who is little complicated group of patients with heart problems or blood pressure diabetes, we have to go for a comprehensive test, which is level 2. Okay, that's it. So sir, what is more comfortable for the patient to get the sleep study test done, in the hospital or at home?
So it depends upon individual patient preference. Few people might be more comfortable sleeping in their own environment, like
Right.
their own bed and the same pillow and all. So in such patients we can do sleep study at home only. That will be level 2. And if the patient's family is okay with a person staying over there, we can just probably do it like a level 1
At home
by
itself.
placing a camera and also like having the recordings observed. So probably in the same room or probably in a different room. So few people have reservations doing at home. They'll have a fear like whether the test would be done okay, and few people for the insurance purpose, like they're getting admitted for some other issue, medical issue. If the admitting hospital has that facility and the patient has this symptom suggestive of OSA, and the treating doctor picks it up and subjects the patient to that test, that can be done at in the hospital only.
Okay.
So it depends upon personal patient preference, which their
Wherever they
particular
are
patient is comfortable, we do the test accordingly. Yeah.
Okay. Sure, sir. And who are the people who require to be screened? Apart from the people those who have diabetes, hypertension, so these people are at the high risk. Who are the people at the low risk or at least moderate risk?
So, as told, people who don't have a very active lifestyle, more sedentary lifestyle, who are slightly on the higher weight range, and who feel that they are not able to give 100% even after lot of effort in their job, like had to concentrate their on job, and forgetfulness, lapse in memory, and not feeling 100% fit mentally and physically. These people can go through this questionnaire and answer themselves, and probably if the risk of having OSA is high, moderate or high, they can get subjected to this sleep study. Yeah.
Sure. So any patient scenario you have, like, where the patient life got improved after being diagnosed?
Yeah, see, so after treating the OSA, most of the people, they have increased energy levels. There are people who had already diabetes and hypertension, their sugar and BP control is better. In few patients we are able to decrease the dosage of medications for controlling this sugar and BP also. And they tell their performance in the work is better, and their mood is better
because the energy is high, so the mood is always better.
Yeah, and they are able to take up any sport or exercise. They are having that energy and enthusiasm to take up a
challenging task.
challenge rather than challenging. People with OSA don't have that enthusiasm or energy. They are in a state of inertia.
Okay.
So once treated, we can see that people are able to go to a walk, or younger generation young people, they are able to take up a sport of their choice. They're able to play and they enjoy it, and family is happy because he is getting involved. Right. More involved in marriages and all, in the marital relationships. The sexual urge is also more, which usually gets decreased in patients with OSA.
Okay.
And their performance in the work also increases. So overall, the health will become better, and the life will become, quality of life will become more better. This the appetite. So a patient who have this abnormal sleep pattern, like this OSA, and bad quality of sleep, increases the appetite.
Okay.
So we have seen patients' appetite also comes down.
Okay.
Not comes down means the voracious appetite comes to a normal appetite. Okay. And craving for high calories. So when we have lack of sleep, like suppose a day I am not able to complete my sleep for 6 hours or 7 hours, I sleep only for 3 or 4 hours. To keep myself active, I crave for high calorie food. I crave for chocolates, excessive coffee, tea with sugar. So those things, that craving will come down.
Okay.
So appetite also gets normalized, and that in turn helps this. So it increases the ability of the patient to exercise. It gives the energy to exercise and decreases the appetite. So it helps in controlling this diabetes also, and
Weight
also
management.
decreasing the weight also. Helps
So,
in
a
managing the
obese
weight.
patient, if he get diagnosed with OSA, and if he's working on his OSA treatment, he can actually work on his diet and exercise, and also in turn get the better weight.
Absolutely. So, like treating OSA itself doesn't decrease the weight, but it gives all the necessary foundation for the patient
Right.
to take up this weight loss, and effective weight loss can happen.
So, end result, effective, healthy weight loss can happen.
Yeah.
Right. Sir. So, what are the treatment options available for obstructive sleep apnea?
So, like again, there are multiple treatment options depending upon the patient profile. So, as we already told, if at all it is because of craniofacial abnormality, it is basically surgery. Like if the, so for example, retrognathia and micrognathia, like mandibular advancement, maxillomandibular advancement operations are there. And if the problem is in the palate, something called ulvopalato-pharyngoplasty surgery is there. And like tonsillar hypertrophy, adenoids, tonsillectomy, adenoidectomy operations are there, especially in the pediatric age group. And in the adult subset, usually, and obese subset, weight loss is the treatment of choice. But we know, like a very obese patient, they can't lose their weight overnight. So, as a bridging, so we use a machine called continuous positive airway pressure machine. So usually, like that machine, what it does, it usually splints the upper airway by a positive pressure. So to explain in simple terms, like when we go to a grocery shop, very thin polythene covers will be there.
Correct.
The person will be trying to open that polythene, it will not be opening. He blows air into that polythene, so it opens up.
Right.
Suppose if he keeps on blowing that air, it will be opened all through. Stay open till the time he blows that positive pressure. The same mechanism acts in this continuous positive airway pressure machine. So that is given with a mask which is connected to the device with a hose. So the machine blows the positive pressure, so that positive pressure will be delivered to the patient via the mask. So the upper airway is opened up and kept open all through. The sleep disturbance or recurrent awakening will not happen. The sleep quality gets better, and these apneas are more in the deeper sleep or rapid eye movement sleep. So the person with OSA, most of them will not be sustaining that deep sleep, which is very important for their relaxation. So the muscle tone is completely lost, so the body gets complete relaxation in the deep sleep, and they get adequate energy to perform the next day the usual activity of daily living. And the mind also gets adequately relaxed. Like that rapid eye movement sleep, we call it as dream sleep. It is the deepest sleep where the people will get dreams. So that deep sleep or REM sleep is sustained and prolonged. So once they get that, they have a very good sleep and they feel very fresh next day morning. So this CPAP is the treatment for any patient initially. The patient who has to undergo surgery or the patient who has to undergo weight loss, till that is done, the bridging treatment is CPAP. Now newer machines have come, something called auto CPAP. So that auto means the pressure will be adjusted according to the patient's position. Suppose the patient is on his back, laying down on his back and sleeping, the pressure required is more because of the gravity, the compression is be more. So when the person sleeps to his right or left, the pressure required will be slightly lesser. So the patient recognizes in one or two breaths what is the pressure resistance the upper airway is posing to the machine, and it adjusts the pressure accordingly and sets it. So this mechanism is given by auto CPAP machine. So fixed CPAP or auto CPAP, according to the patient profile, the sleep physician prescribes that machine they can use till they reduce the weight or undergo surgery. Till then, they can get a good sleep with this machine. Yeah.
So this machine is a savior for the patient who are having blockage in the airway.
Yeah. Suppose the patient is old, like elderly, in whom we can't expect them to lose weight or rapid weight loss, or they can't exercise because of arthritis, by any other health issue. In them, the CPAP becomes the treatment
choice
for long term also by default. Yeah.
But even in the younger generation, I think CPAP can bridge the gap between.
CPAP is required for everybody.
Okay.
Till the cause for that OSA is resolved, whether it is weight or whether it is
any other cause,
airway abnormality or facial abnormality. Till that actual treatment happens or weight loss happens, CPAP is the treatment. Yeah.
Okay. So, any other treatment apart from CPAP? What the other treatment of choice?
So there are other types of OSA, means positional OSA. People they have more apneas, or this the problem of OSA is more when they lie on their back, and it is very less when they sleep in right or left lateral position. In such patients, something called sleep vests are there. Usually there will be a solid material in that vest, whether a t-shirt or any t-shirt or a shirt or the bunions what we wear, that will be stitched in the backside with a solid material inside, like tennis ball or a hard material. So when the patient assumes that supine position or comes on his back while sleeping, he becomes uncomfortable and automatically he goes into the right or left lateral position. So that is one of the treatment for that positional OSA. And there are many other new methods of treatment which are available, like hypoglossal nerve stimulation. Basically, we all understood that the OSA problem appears in the upper airway,
right,
because of the increased collapsibility of the upper airway. So, by stimulating the hypoglossal nerve, which usually supplies the muscles and the tongue in the upper airway area. So by stimulating that, the tonicity of those muscles will be kept intact even during the sleep.
Okay.
So that they'll not collapse. So these are still under trial, and I have not seen, at least in my career, anybody who has undergone that treatment. But that is a treatment of utmost possibility in near future. Probably we can have those type of treatment in India also.
Yeah. There's something called as taping mouth also is helping OSA. Is that true?
I have seen on many social media platforms and all, right. But I think what is the basis of those treatment and all? Probably with my understanding about OSA and all, I don't think it is going to work.
Okay. So as a doctor, your advice is that mouth tape may not help them. They should go and meet the doctor.
Yeah, even if they use it, I don't think they might get adequate relief of the symptoms. Sooner or later, they are going to visit one of the sleep specialists.
Okay. So regarding obstructive sleep apnea, many people are having different types of doubts, or they have some kind of myths. So I will tell you whether these are myth or truth, and you can explain more about it. So all snorers are having sleep apnea. So anybody who is snoring is actually suffering from sleep apnea. Is it true or not?
So most of the patients who have OSA will have associated snoring, but all snorers may not have obstructive sleep apnea, because snoring is basically a sound which gets produced in the upper airway because of abnormal air passage. So if there is nasal obstruction, deviated nasal septum, as I told, adenoid hypertrophy, tonsillar hypertrophy, all these things can cause snoring. But patients who have snoring should be evaluated for OSA by these questionnaires. And if high chance of high probability is there, then better to get the sleep study done. But if probability of OSA is less, first by upper airway examination by a specialized doctor like ENT physician or ENT surgeon, they have to assess the upper airway, what is the cause of snoring, and particular treatment for the particular abnormality should be given. But this is a myth, like all snoring is because of OSA. That's a myth.
And my second question is, nothing happens to OSA patient if they don't opt for treatment. A lot of patients, those who get diagnosed for having mild, moderate, or severe OSA also, they take treatment very lightly. They say, okay, fine, let's see. Anyway, it is not paining me today, so I'll see later. So they want to delay the treatment process to 4-5 years or 10 years also.
So, like all these diseases, like diabetes, hypertension, all these diseases, like the symptoms might not be very severe in the beginning, but the complication of those diseases are very severe. So, it is very important that anybody who has OSA should not ignore that condition. Like definitive treatment by weight loss or surgery is very important, and till the definitive treatment happens, like getting treated with a CPAP machine is very important, because we have already discussed like what are the complications of untreated OSA. Like,
And then there is a myth, say, like it's myth or truth that you will say, but sleep apnea impact only sleep, but not any other function.
no, like the basic quality of sleep is not that good. So, like when the quality of sleep is not there, definitely it affects the like next day's activity, and not only the activity, all the health is also getting affected in the long run. So it's not only the sleep, but overall general health of the person is affected by this OS.
The whole health part
the
is
mental and physical health of the patient is getting affected.
No.
Like overall, like the attention of the patient, the concentration on his work, focus on his work, his agility, his energy levels, and enthusiasm, and vitals like heart rate, blood pressure, and oxygen levels during the sleep, everything is getting affected. And a person, we can ourselves see the day when we have a very good sleep, we feel very relaxed, energetic, and ready to go for any work. But we sleep less, or some disturbance in the sleep is there multiple times in a night, next day will not be very energetic and enthusiastic, will be agitated. So that effect will be there in the long run in patients of OSA.
Stressed out with small things.
Yeah. They get annoyed very quickly.
Correct.
Yeah.
Slim body frame people will not be affected by OSA.
No. So as we told, like obesity people, yes, high chance of getting OSA. Like thin people who have that abnormalities in the upper airway, they can definitely get. So it's not about obese or lean body habitus, but the symptoms we have to concentrate upon. So even people who have those symptoms of OSA who are lean, they should be tested for OSA.
And treatment for sleep apnea is difficult.
See about the overall complications of OSA. Suppose a patient spends around 70,000-80,000 and buys that machine and start using it, and works towards his better health by weight loss and regular exercise and all, he can prevent a devastating complication like a heart attack and stroke. So if at all he thinks about this cost of the machine now, he ends up spending 3 times or 4 times the money in future. And also money is a secondary thing. The complications of that stroke or heart attack, like he has to lose his work for some time till he recovers from that, and whatever the pain he has to undergo with those diseases, that is an added complication. So better to get treated for OSA. I know it is costly, but in the time to come, like cheaper and better options for treatment might come.
Right. So cost of not treating is the irreversible damage.
In the long run, I think like both physically and economically, the cost for the patient will be more.
Right. And so there are, for especially somebody who has got diagnosed with OSA, and for treatment if they have been prescribed the auto CPAP device. So many patients feel that, okay, once I start the CPAP device, I will not be able to sleep without it, and it is a habit forming. I'll get addicted to sleep with
machine.
CPAP device only.
Yeah.
Mainly the patient himself or the family members are feeling in that way. So they are searching around what else I can.
Yeah. So see, basically the CPAP is a mechanical device. So it just opens up the upper airway and keeps it open throughout the night.
Okay.
So addiction, obviously, like if the definitive treatment by a surgery or by weight loss doesn't happen, the patient will not get good sleep without the machine. He'll have those symptoms. In that way, definitely the machine is very important, and probably the patient is dependent on that machine for a good sleep. So, like, it is very abnormal to think like the patient is getting dependent on the machine, like he is depending upon the machine for good.
Right.
Like without the machine, there is no good sleep for him unless until definitive treatment happens. So definitely the patient will be dependent on the machine for good sleep, and it is a good dependence.
So instead of attracting sudden death due to blockage of airway in the sleep, it is always better to get dependent on a device which is helping to breathe better during sleep.
Yeah.
Okay, sure. So any 4 or 5 things which you want to tell to our viewers, that if any 5 advices about sleep or sleep apnea.
So like OSA is a preventable disease, especially in people with obesity and all, like who are unhealthy lifestyle and sedentary lifestyle, eating more junk, eating more calories. They gain more weight and turn into obesity, and that can lead to OSA. So in this subgroup of population of OSA, like it is a preventable disease. So I urge people to take up healthy lifestyle practices, keep control on their calorie intake, and regular exercise, at least 45 minutes to 1 hour of any physical activity they have to do. So that we can prevent gaining weight and getting OSA. And for the patients who have already been diagnosed with OSA, it is a treatable disease. And the patients who are not getting treatment, I advise them to be like very disciplined with the treatment, use the CPAP very regularly. If there is any discomfort with the machine, they can come to the sleep specialist or the sleep technologist, or the person who has given them the machine. They can consult them. Minor adjustment in the pressures and in the like some adjustment in the special qualities of the machine, like the pressure release or adjusting the ramp and all, they can help the patients to like adapt better or tolerate the machine better. Okay, so they have to ask and overcome the problems with the machine rather than stop using the machine. And even patients with treatment with CPAP machine, like putting the CPAP is all not enough. You have to give adequate time to sleep also. So few patients of OSA, they'll do everything correctly, like they'll sleep, they'll put the machine, but the duration of sleep is less because of stress and work pressure and all. They put the machine, they sleep only for 3 or 4 hours. Obviously, even with CPAP, if you sleep for 3 or 4 hours, the quantity of sleep is not enough. The quality of the sleep is good. So at least everybody should sleep minimum of 7 hours to 8 hours per day.
Thank you so much for coming to our platform and giving clinically verified advice about obstructive sleep apnea. I think we have got a lot of information about sleep apnea today. And for the viewers out there, I would say, if you are having any of symptom like snoring, tiredness, daytime sleepiness, or dozing off while sitting at and waiting for someone, or just like that at unusual places, you must go and meet a doctor like Dr. Sagar, who is a pulmonologist or a ENT doctor or sleep specialist, who can help you overcome these symptoms. And
from my side, I even thank you for giving me this opportunity to speak about this topic of obstructive sleep apnea, which I'm having a special interest in. And it's been a pleasure, like conveying this, whatever the knowledge I have about OSA in sharing this with people. Thank you.
Thank you. Thank you.